Welcome back to Endo in a Bite. This is part 4, the final episode in our series on primary aldosteronism. So far, we've talked about ARR pitfalls, both false negatives and false positives. Today, we're moving beyond screening into what comes next: suppression testing, cortisol cosecretion, adrenal vein sampling, and treatment pearls that really change outcomes. Let's start with aldosterone suppression testing. We should be doing this selectively. It's not a blanket requirement. The panel recommends suppression testing when screening results suggest an intermediate probability for lateralizing PA, and the patient is actively considering surgery. This is not for someone with classic overt disease or someone unlikely to pursue adrenalectomy. So what does intermediate probability mean in practice? Think of a patient with renin suppression and a plasma aldosterone in that borderline range without overt hypokalemia. In that context, suppression testing helps clarify whether autonomous aldosterone production is real before jumping to adrenal venous sampling. On the other hand, suppression testing is not recommended if the patient has a very high likelihood of PA. In those cases, the risk of false negatives with suppression outweighs the value. Now let's talk about cortisol cosecretion, which we don't want to miss in PA patients with adrenal adenomas. The guideline advises to perform a 1 milligram overnight dexamethasone suppression test with all PA patients that have an adrenal mass. You're looking for a serum cortisol 1.8 milligram per deciliter the next morning, which suggests mild autonomous cortisol secretion that has implications for surgical management, perioperative steroid coverage, and even long-term metabolic risk. If surgery is being considered, adrenal vein sampling is strongly recommended to determine laterality. CT alone is not sufficient. Even when a unilateral adenoma is seen, imaging cannot reliably distinguish between bilateral hyperplasia and a true aldosterone-producing adenoma. There are a few exceptions, such as patients under age 35 with classic findings, spontaneous hypokalemia, markedly elevated aldosterone, suppressed renin, and a clear-cut unilateral adenoma, 1 centimeter on CT. In those rare cases, AVS might be skipped. But in general, CT plus AVS is the standard of care to confirm unilateral disease before adrenalectomy. Once the diagnosis is made, the guideline emphasizes treat PA specifically. This isn't just about blood pressure control. The goal is to mitigate the long-term cardiovascular and renal risks unique to aldosterone excess. If you've confirmed lateralization and the patient is a surgical candidate, unilateral adrenalectomy is preferred and can be curative. If the patient has bilateral disease, is not a candidate for surgery, or simply declines it, lifelong medical therapy with an MRA is the way to go. Now, spironolactone is the preferred first-line mineralocorticoid receptor antagonist. The recommendation here is driven by its low cost and wide availability. While other agents may have fewer anti-androgenic side effects, all MRAs, when titrated to equivalent potencies, are similarly effective in treating PA. The guideline also discourages the use of ENaC inhibitors. Those may be useful in other contexts, but they're not considered PA-specific therapies. Finally, there's an important point about titrating MRAs. In medically treated patients whose BP remains uncontrolled and renin is still suppressed, the recommendation is to increase the MRA dose, not just to control blood pressure, but specifically to raise renin. So in summary, do suppression testing selectively, not universally, and only if the patient is surgical-minded. Screen for cortisol autonomy in adenoma cases. Confirm laterality with AVS. Treat PA directly. Start with spironolactone. Avoid ENaC inhibitors. And titrate your MRAs with an eye on renin, not just BP. That wraps up our 4-part series on primary aldosteronism. In this bite, we covered when suppression testing is useful, why cortisol cosecretion matters, how adrenal vein sampling guides surgical decisions, and the treatment roadmap, from curative adrenalectomy to lifelong MRA therapy. Thanks for joining me through this focused series. For full notes and weekly pearls, head over to www.easyendoprep.com. I'm Dr. Sumbulbag. Remember, stay consistent and keep it bite-sized.